Hello, I'm David Keren from the Department of Pathology at the University of Michigan. And today I'm going to be discussing the newest methods to detect monoclonal proteins. These are known as M-proteins. M-proteins are immunoglobulin products secreted by plasma cell tumors. The methods we're going to talk about today include capillary electrophoresis, serum-free light chain measurements, and heavy light chain measurements. I have some disclosures to make. I get some financial support from Sabia. I consult for them and I give lectures for them. I'm also a trustee of the American Board of Pathology, and I receive royalties for a book I write on protein electrophoresis that is published by the American Society for Clinical Pathology Press. During this session, I'd like you to please enter your questions while I'm giving the presentation. But unless something looks urgent to me, I'm going to probably answer them all at the end. After this lecture, my objectives are that you will be able to implement a process for detecting M-proteins, that you will understand the value and the challenges of immunofixation and immunosubtraction techniques, that you'll be able to recognize several causes of false positive and false negative tests by these methods, and that you'll understand the value and concerns about both the serum-free light chain test and the rather new heavy light chain test. So, what are monoclonal gammopathies? These are disorders that are caused by clonal proliferations of plasma cells and by their products. These products, termed M-proteins, are immunoglobulins that are produced by the plasma cell clones. The detection of such products helps in the initial diagnosis, the stratification of the risk that these processes progress to a malignancy, and in following their response to therapy. Some of these diseases, such as multiple myeloma, are mainly due to the large tumor burden. Others, such as AL amyloid and the others that I've listed here, may have lower tumor burdens but cause damage to many tissues due to the altered forms of the monoclonal immunoglobulin product, termed amyloid. Finally, some of the conditions are classified as premalignant. They all have the potential to progress to multiple myeloma and other malignant disorders. But at the present time, they would be asymptomatic. These would be monoclonal gammopathy of undetermined significance, a mouthful of a term that we abbreviate as MGUS, and smoldering or atypical multiple myeloma. Multiple myeloma is the most malignant of these conditions. It's relatively common, and it accounts for about 10% of hematologic malignancies across the United States. Now, while this condition usually occurs in older individuals, it can be found in individuals under the age of 40. The M-protein that we detect in multiple myeloma was in fact the very first measurable tumor marker discovered over 150 years ago. The incidence of multiple myeloma varies depending on gender, with men having a higher incidence than women, and also by race, with blacks having a higher rate than whites or Hispanics, and Asians having the lowest overall rate. The fact that there is differences based upon race and gender, along with familial occurrence of the disease, implies that there is a genetic component to multiple myeloma. Now, while the methods that I'm presenting this morning are robust, false negatives can occur, because while M-proteins usually migrate in the gamma region of electrophoretic gels, as I'll show you in a minute, they can migrate in the alpha or beta regions. When they do this, their presence can be obscured by some of the normal serum proteins that I've listed here. In this session, I'll show you ways that we can detect these obscured M-proteins by looking for suspicious findings on the electrophoretic patterns. In addition to the false negatives, We can have false positives when other serum proteins, like fibrinogen, are present. With capillary electrophoresis techniques, radiocontrast dyes, and some drugs, especially antibiotics, can give suspicious bands. The serum-free light chain test is performed by a technique called nephelometry. Free light chains used to be detected mainly by doing a urine immunofixation. I've abbreviated here by IFE. However, that test requires urine, and often all we receive are serum samples. But recently, the serum-free light chain test has been developed as a nephelometric assay by Bradwell and colleagues. I'll go over this test in some detail. It is a very handy test. However, it is subject to a problem called the high-dose hook effect, also known as antigen excess effect, and I'll show you an example of that. Even with that problem, however, free light chain test is a very important tool, especially for looking at the unusual case of oligosecretory or non-secretory multiple myeloma. Let's look at the types of M-protein products that we're looking for. This data is from a classic study performed by Kyle and colleagues at the Mayo Clinic. They reported that the majority of newly diagnosed cases of multiple myeloma secrete IgG. About 20% of them make IgA. But you'll notice in the green piece of the pie, about 20% of cases make only the very small free light chain molecules of kappa and lambda. And that's important because those cases are hard to detect by just looking at serum protein electrophoresis. Because these free kappa and lambda chains are so small, they readily pass into the urine and can be detected there by urine immunofixation. However, the serum-free light chain test that I'll describe in a moment is an effective means to detect these molecules by automated nephelometry in serum. IgM M-proteins are usually not secreted in multiple myeloma. They're found in a condition called Waldenstrom macroglobulinemia that we're not going to be discussing today. Other components, such as IgD, biclonal, IgE, are rare. Serum and protein electrophoresis can be performed by either gel methods, where samples of serum or urine are assayed on a solid surface, or by capillary zone electrophoresis, which is a free-flowing system that I will show you in a moment. With gel techniques, after we've detected an M protein, we want to identify their isotype, that is GAM, kappa or lambda, and we do that by immunofixation. With capillary electrophoresis, we identify them by a technique called immunosubtraction that I'll show you now. When urine protein electrophoresis is used, immunofixation is usually used to identify them. Gel electrophoresis is usually performed on agarose gels these days at an alkaline buffer pH of 8.6. At that pH, all serum proteins are negatively charged. Therefore, they're attracted to the positively charged anode. However, the gel itself has a net negative charge, such that the positively charged ions in the buffer migrate toward the cathode. This creates a stream of movement toward the cathode called endosmotic flow. Now, because of this flow of buffer ions, the weakly anionic gamma globulins end up being pulled toward the cathode. Note that they're on the cathode side of the origin. Normal serum has the major proteins shown in this cartoon. Albumin, toward the anode, is the large band. Alpha-1 globulin, alpha-2 globulin, beta-1 globulin, beta-2 globulin, and gamma globulin. The amount of protein in each major band is determined by making a densitometric scan of the gel and using a total protein measurement of serum to identify the quantity in each region. Here are two samples of real cases. On the top, we see a normal sample. Note in the gamma region, toward the right, is quite smooth and very broad, staining with a faint blue. Below it, is a case from a patient who has multiple myeloma. Note that in the middle of the gamma region, there is a very dense band. This is the immunoglobulin product of those plasma cells and the M-proteins. When performing gel-based techniques, one has a variety of products to choose from. I prefer using a gel that provides a crisp separation of the two beta region bands. Beta 1, as I show here, is transferrin. The second beta region band is the third component of complement, C3. As you can see, as we move down the scale toward poorer resolution from different products, the distinction of these two bands becomes less reliable. I think this separation is important because many M-proteins will migrate in the beta region, especially IgA M-proteins. With better resolution, one can be suspicious if there is a distortion of one of those bands. I'll show you such a separation in just a moment. With capillary electrophoresis, there is no solid support. The samples of serum are aspirated into the anodic end of a thin, strongly negatively charged silica capillary tube. Because of the negative charge on its interior walls and its high pH, this is performed at pH 10, a very strong endosmotic flow pulls the proteins past the detector. This detector measures the absorbance of a 214 nanometer signal. This is used because this is the wavelength at which peptide bonds absorb, thereby identifying the protein. Now, after the proteins pass through this, their bands are detected in a sample called the electropherogram. This is the resulting electropherogram on a normal sample. Note the crisp separation of transferrin, beta 1, and C3, beta 2 bands that I've indicated. You can also see many of the other bands that are of importance. This is serum from a patient who has a large monoclonal gammopathy, but clinically, this patient was asymptomatic. There was no increase in calcium, no anemia, no renal disease. Because there were no clinical problems, this patient was classified as being one of the premalignant conditions, monoclonal gammopathy of undetermined significance, MGUS. There's a prominent M spike in the gamma region, and I've colored it for you in pink. And this is how we measured the sample. In this case, you may see at the bottom, it measures 2.2 grams per deciliter. Now, the larger the M spike is in patients with MGUS, the higher is their likelihood of progressing to a malignant condition relatively soon, such as multiple myeloma. After detecting and measuring the M protein, it's important to determine if the M protein is IgG, IgA, IgM, or rarely IgD or IgE. Patients with an IgG MGUS are less likely to progress to multiple myeloma than those who have an IgA MGUS. It's also important when you follow the patients after therapy because the MGUS, the monoclonal gammopathy, may disappear, and then with therapy, sometimes you get the production of smaller reactive bands that could be confused if you didn't identify the original isotype. We can characterize the M protein by either immunofixation or immunosubtraction. Immunofixation is used on gels, while immunosubtraction is used in capillary electrophoresis. Although immunofixation is more sensitive and versatile because it does pick up the rare IgE and uncommon IgD cases, I found immunosubtraction to be useful in helping me to measure some M proteins, and I'll show you an example of that during this talk. Immunosubtraction also requires less technologist time and is less likely to be affected by a manual pipetting error. For immunofixation, we apply the sample to 6 lanes of an agarose gel. In this cartoon, I'm putting the anode at the top. We perform electrophoresis then to separate the various proteins, but none is yet visible. Then, in lane 1, we fix the proteins in place with an acid. But to the other lanes, we apply a specific antisera against IgG, IgA, IgM, the most common heavy chains found, kappa, and lambda, the light chains. We wash and stain and get a pattern that looks like this. This shows a normal immunofixation. Note that normal IgG is diffuse and located in the gamma region, while normal IgA is also diffuse, but is located more anodally toward the beta region. There's very little IgM present in this case, and the kappa and lambda, which in this case are attached to IgG, A, or M, are both diffuse and mainly in the gamma region. Keep these features in mind as we look at the next case. Here, IgG is still diffuse, but a bit darker. This reflects the presence of more protein. However, if you look at the IgA lane, as the arrows show, there is a distinct band at the anodal end. A band with the identical migration as the IgA band is present in the kappa lane. This identifies it as an IgA kappa M protein. You can see it over in the serum protein electrophoresis, SPE lane as well, just a bit obscured by the presence of other bands. For capillary electrophoresis, there are no proteins to fix in place because it's a continuously flowing system. So I show you how we deal with this in the following cartoon. On the top left in this cartoon, I show the electropherogram with the anode at the left. The pattern has a normal albumin that I've indicated by the purple band, but a prominent spike is present in the gamma region. I say that this spike is an IgG kappa. So below this electropherogram, I show how the IgG kappa molecules might have lined up as they passed by the detector to identify the light chains in this gamma spike. Now, to identify them, I used an antisera against kappa, anti-K. I mixed that with the serum and put it through the capillary again. These anti-kappa immunoglobulins bind all kappa-containing molecules. This results in a very bulky antigen-antibody complex, as I've indicated below. Because of their bulk, they migrate more slowly through the capillary and are now found in the albumin region. The image below shows that only lambda-containing molecules remain in the gamma region as they pass by the detector. In effect, the M spike has been immunosubtracted with anti-kappa, letting you know that kappa is a major component of this spike. Let's see how that works in practice. Here's an actual immunosubtraction. It shows the original electrophoresis pattern in the top left panel. It contains a prominent spike in the beta region. In the top right panel, the black line indicates the original position of the spike, while the blue lines show what happens after treatment with antibody to IgG. Similar to the kappa in the cartoon, the IgG-containing molecules have been immunosubtracted from the beta region and moved toward albumin, which I indicate with the red arrow. In the middle two panels, the results of pretreatment with anti-IgA on the left and anti-IgM on the right show that the blue spike remains essentially unchanged. However, comparing anti-kappa on the bottom left panel with anti-lambda on the bottom right panel, we see that the anti-kappa subtracts the spike while the anti-lambda does not. This identifies the M spike as an IgG kappa M protein. M spikes that are due to small molecules can readily be identified in the urine, and that's classically how we've detected them for many years. While intact IgG weighs about 160 kilodaltons, monoclonal-free kappa chains weigh only about 25 kilodaltons. and free lambda chains that exist mainly as dimers weigh only about 50 kilodaltons. Therefore, these free light chains readily pass into the urine, while IgG does not. To detect free light chains, one can perform urine protein electrophoresis on concentrated urine. Here, I show several samples of urine, some with moderate glomerular damage, permitting large amounts of albumin, and a few other proteins to pass into the urine. In the third sample from the top, there is a minor tubular injury shown by several lightly staining bands to the right of albumin, but there's also a distinct spike indicated by the arrow in the gamma region. This spike was a monoclonal protein that was characterized as kappa-free light chain by performing immunofixation. To measure it, the International Myeloma Working Group recommends that a 24-hour urine sample is collected, the total protein is measured, and a densitometric scan, as shown here, is performed to determine the fraction of monoclonal free light chain. Here, it was measured by densitometry and found to contain 9,636 grams in 24-hour period. With the 20% of cases that I showed you earlier that are classified as light chain myeloma, this is the test that is still recommended to follow patients who are on various chemotherapeutic regimens. Normal plasma cells produce the heavy chains, gamma, alpha, and mu, separately from the light chains. When the light chains are produced in excess, they pass into the serum and are quickly excreted into the urine. That's why urine protein electrophoresis and immunofixation techniques have been the standard for initial detection of monoclonal free light chains for many years. However, free light chains do exist in the serum, and with a sensitive enough technique, one can measure free kappa and free lambda chains in the serum. That is the importance of the new nephelometric method to test for serum free light chains. However, while this test is useful for initial detection of monoclonal free light chains, one still needs to collect 24-hour urine afterwards to follow patients with light chain myeloma. Here's a brief summary of how antibodies specific to serum free light chains are made. In the cartoon at the right, I show theoretical antigenic determinants, which I'll call epitopes, on the surface of the free light chain, A, B, C, D, E, and F. Now I've labeled E and F in red because they indicate epitopes that are specific for free light chain. In the bottom right cartoon, I show why that's so. Those are the epitopes that are specific for free light chain molecules because they're bound to the heavy chains and are on the interior of the molecule and not available to bind anti-free kappa chains. Bradwell and colleagues took advantage of this fact to create antibodies in sheep by specific immunization and extensive absorption studies. This is important because large molecules like IgG, which contain two identical heavy chains and two light chains, either two identical kappa or two identical lambda, have a half-life of about 3 weeks, while light chains have a half-life of only a couple of hours. Consequently, the amount of light chains that are attached to heavy chains in serum occur at about 1,000 times the concentration of the free light chains. So, after these specific antibodies were created, Bradwell and colleagues published a key paper. And here's data from their original work. It graphs the free light chains concentration on the x-axis, the free lambda light chain concentration on the y-axis. And these are log graphs, as you see. Normal sera are shown in violet. Individuals with renal disease are in the turquoise blue. Individuals with renal disease can't excrete the light chains as readily and have higher amounts of both free kappa and lambda in their serum. However, the key is that the ratio of kappa to lambda is normal. Note the rectangular normal kappa to lambda ratio box placed around these samples. In contrast, patients who have free kappa myeloma have their results in the bottom right as black squares. None of these are in the normal range for kappa and lambda ratio. And those with free lambda myeloma have their results separate as blue triangles in the upper left. Also shown on this slide are patients who have AL amyloid. These are shown in white, depending on, and they are either mostly above or below the normal rectangle area, depending on whether they're kappa or lambda. However, note, it doesn't separate all cases of AL amyloid. Much less tumor burden, much less protein is made in many of these cases, and they cannot all be distinguished, even by this technique. A year after Bradwell's initial paper, Katzman and colleagues from the Mayo Clinic showed that by using a diagnostic range that excluded all 282 reference samples that they used in their study, they could improve the specificity from the 95 confidence interval, which would be the 0.3 to 1.2 range, to over 99%, while retaining the sensitivity of 99+%. Katzman did further studies to show how effective this range would be in picking up known cases of free light chains that they had detected at the Mayo Clinic. They looked at serum from 428 patients who had known urinary M-proteins detected initially by immunofixation. And Katzman found that they could detect 99.5% of these cases if serum immunofixation and serum free light chain measurements were performed. They didn't need to use urine at all, and they missed no cases of multiple myeloma. The only two cases that weren't picked up with this, one was a case that likely was from a contamination and was a false positive, and the other case was a case of MGUS, which is a non-malignant condition at the present time, although it can progress to a malignant condition and just needs to be followed. The International Myeloma Working Group has suggested guidelines for how to use serum-free light chain test. As I've just shown you from the Katzman data, the serum-free light chain test can substitute for urine in the initial workup of patients suspected of harboring a monoclonal gammopathy. Secondly, the baseline measurement of the serum-free light chain test at the time of initial detection provides useful prognostic information for all plasma cell dyscrasias, myeloma, Waldenstrom's, or MGUS. Further, it is very useful to detect and follow AL amyloid, light chain deposition disease, LCDD, and oligosecretory myeloma. Oligosecretory myeloma implies very small amounts of the M protein are produced. In all these conditions, the serum-free light chain test has been shown to be as, if not more sensitive than immunofixation, and a very helpful aid. Finally, serum-free light chain tests, FLC, have been established as a criterion for stringent complete remission during therapy. However, it is not suggested to be used to follow cases of light chain myeloma. At the present, the guidelines recommend using a 24-hour urine where you measure the densitometric scan, as I just showed you. It's also not used when a patient has an intact M protein that is followed in the serum, which is about 3/4 of the cases. So here's an algorithm to detect multiple myeloma that can be used. If a clinician suspects that a patient may have a process that is consistent with a monoclonal protein, both a serum protein electrophoresis and a test to detect monoclonal free light chain should be performed. The monoclonal free light chain test classically had been immunofixation on concentrated urine, but these days, as I just showed you, the serum free light chain test can substitute for that. On serum protein electrophoresis, some laboratories automatically perform immunofixation. Others look to see if there is a suspicious band before performing immunofixation IFE, or immunosubtraction, I sub. So what does suspicious mean? There's a nice study published in 2010 by Dr. Katzman again at the Mayo Clinic, and he categorized several suspicious cases. They looked at 621 cases that had been followed up at the Mayo Clinic. His first category was fuzzy band. 206 cases fell into that category. Of those patients, when they performed immunofixation, IFE, over half of them, 54%, were positive for a monoclonal protein. He also categorized some as questionable fuzzy bands. I've actually never pinned Dr. Katzman down on the difference between questionable fuzzy band or fuzzy band, but I believe these were the impressions of the individuals who read the samples, and it probably varies a bit. But clearly there is a difference, because when you look at the 263 patients that had questionable fuzzy bands, they definitely had monoclonal proteins, in many cases 18%, but it wasn't as high a percentage as when a definite fuzzy band was present. I will show you a fuzzy band in just a second. Hypogammaglobulinemia is another important finding. They had 85 patients with hypogammaglobulinemia, and 12% of them had monoclonal proteins at that time. Increased alpha-2 region, greater than 1.4 grams per deciliter, was found in 48 patients. Only 2 of them, 4%, had monoclonal proteins. So you're less likely to find monoclonal proteins in the alpha-2 region, but you can, and I will also show you that. Increased beta region, and their criteria was 1.6 to 1.9 grams per deciliter. Out of the 10 cases they had, one of them, 10%, was positive. So, let's take a look at the case. Where is the M spike on these 5 cases? Well, if you look down at them, if you look at the gamma regions and the beta region, the bottom case has a very large band that's right at the origin between the beta and the gamma region. And that could be an M protein, but when we did further studies, it was fibrinogen. This was a patient that had been anticoagulated, and fibrinogen was not removed, and we're just seeing the fibrinogen band. But if you look at the C3 bands on all the different areas, that's the beta-2 band, you'll notice that the one in the second sample, indicated by the arrow, is broader. It's fuzzier than the other bands. And the fuzziness is because there's a monoclonal protein that is migrating directly on top of it, but also a little to the left and the right of it. Since our staining here is merely a protein dye that will stain any protein, whether it's C3 or a monoclonal protein, the band appears fuzzy. What is the proof that it's a monoclonal protein? We did an immunofixation, and it was an IgA lambda M-protein. As we showed you earlier, IgA monoclonal proteins tend to migrate in the beta region. Because of that, it's important to have a method that has very crisp separation of beta-1 and beta-2 bands, so you can pick up on subtleties like this. Another study was performed on hypogammaglobulinemia, confirming Katzman's findings. This study was performed by Lakshman R.E. Anand and colleagues, and was published in American Journal of Clinical Pathology. Here, they looked at 380 patients who had hypogammaglobulinemia. Of them, they found that almost 10%, very similar to the 12% that Katzman and colleagues quoted, had, by immunofixation, a monoclonal protein that was present either on serum or urine. Here's one of the cases that they show in their article. There's hypogammaglobulinemia in the gamma region, and on this same case, when they did immunofixation, it stained with kappa and lambda as a discrete spike. So what was the importance of detecting these? Did these patients have a clinically relevant issue? And the answer is yes, the patients did. More than half of them had a malignant process. Most of the malignant processes were multiple myeloma, but they also had other cases of B-cell neoplasms, amyloidosis, and one individual had post-lung transplantation with peripheral neuropathy. The rest had MGUS, which needed to be followed. Capillary electrophoresis. Here we have a patient that has an unusual finding. Can you see where it is? It's in the alpha 2 region. It's a very discrete spike. This is not how the alpha 2 region should usually look. So we performed an immunofixation, shown on the next slide. There's a nice normal G area, normal A, normal M, normal kappa, and normal lambda. There's nothing, and there's no spike seen in the alpha 2 region. So what was that? That was one of the artifacts we talked about earlier. Dr. Bossett and colleagues reported in clinical chemistry that one finds artifacts like this when radiocontrast dyes are present. Here I show a photo from his original paper showing that urographin has a band in the anodal portion of the alpha 2 region. Telebrix and omnipaque have restrictions in the more cathodal end. Here is our case, and it lined up with omnipaque. By checking the patient's chart, we found out this patient, in fact, was given that radiocontrast dye. What about having high alpha 2 regions as suggested by Dr. Katzman? Well, here we have a patient who has two suggestive findings. The alpha 2 region is high. You'll notice it measures 1.9 grams per deciliter, and it's flagged as being high. And the patient also has a low gamma globulin. It's less than the 0.55 that Dr. Katzman recommended. So what is that band? It looks a little unusual. We performed an immunosubtraction, and now you are experts at immunosubtraction. And so you see that that band is subtracted out by IgG, not by A or M, and it is subtracted out by kappa. Here is a lighter line rather than the gray versus blue, and not by lambda. So this is an IgG kappa monoclonal dermopathy. The fact that we know where it's subtracted out helps us to determine where we should measure this band. And this way we were able to measure the band as 1.1 grams per deciliter and could follow it. What about subtle beta region M-proteins? This study by Narayan and colleagues looked specifically at the beta 1 and beta 2 regions in over 3,000 consecutive patients. They found 36 who had elevations in the beta region, beta 1 or beta 2, but there was no obvious spike, so they performed immunofixation on those cases. 1/3 of them had a monoclonal protein detected at that time. What was the significance of the monoclonal protein? 2 had multiple myeloma. Therefore, our laboratory performs an immunofixation anytime we see an elevated beta region where there's not an obvious beta-gamma bridge or big spike, where there's a distorted, fuzzy beta 1 or beta 2 band, and you're all now experts on fuzzy bands, or where there's beta 1, beta 2 bridging. Let's see an example. Here's an unexplained increase in the beta region. It's being labeled as high. And so let's do an immunosubtraction, just looking at the globulin fractions. You'll notice here that the IgA and the kappa are subtracting part of this beta 1 region spike, and you can see the normal transferrin underneath it. Lambda is not subtracted at all, neither does G or M. So this is an IgA kappa monoclonal protein in the beta region, and this is why that beta region was increased. Let's look at another challenging problem with the newer assays. Here's a sample, here's a case that was reported from the Mayo Clinic, a 53-year-old woman who had MN, multiple myeloma, and she also had some lytic lesions. She had lytic lesions in her right humerus. The biopsy showed it was 70% plasma cells, all kappa. Her urine showed, UPEP, urine protein electrophoresis, showed a small kappa spike that measured 32 milligrams in 24 hours. They also did the serum free light chain test. It's much more convenient than the urine because you just need the serum sample. You don't have to collect urine for 24 hours. And that showed that the kappa was increased, 4.72 milligrams per deciliter. The normal range only goes up to 1.94, while the lambda, L, was decreased to 0.21. The normal low range is 0.57. They decided to follow the patient at that time by looking at the serum free kappa chains, and it stayed below 5. No therapy was given. However, with time, the patient became anemic and calcium increased. Therefore, 5 months later, they decided to repeat the urine protein electrophoresis and found that it had increased tenfold from the original sample. They gave therapy, and then they found a paradoxical increase of the serum free kappa. Let's see how this looks. This is the course of this patient's disease. Here we have, on the far left, is 0 days, and that's the initial sample. We have the small amount of free kappa, it's under 5 milligrams per deciliter, and we have the urine measured M spike, and I have that axis in green, and it wasn't very large either. Then they followed the patient with the serum free kappa, and it never got above 5. But then they looked at the urine again on day 150, and we had a huge spike. Therapy was given here, and after the therapy, the amount of the free kappa and the serum free light chain test went way up, well over 200. How can it be? It's supposed to go down. That's because there was actually a large amount of it present before therapy, but we couldn't see it because of the antigen excess effect. So what is that? Well, let's take a second to review the typical antibody-antigen reaction curve. If you look at precipitation, and that's what we're really looking at with nephelometry, when there's antigen excess or antibody excess, you don't get optimum precipitation. You get optimum precipitation in the equivalence region. Why is that? Well, it's because in the zone of equivalence, you form large antibody-antigen complexes, where the ratio of antibody to antigen is about 1 to 1. When you have large amounts of excess antigen, such as seen at the right, the ratio of antigen to antibody is huge, maybe 10 to 1. In this case, you're only going to form simple complexes of 2 antigens to 1 antibody. Since here the antigens are small molecules such as kappa, they only weigh 25 kilodaltons. That plus the 160 kilodalton IgG means you're still under 200 kilodalton. That is not going to form a particle that will be detected by nephelometry. And so it will appear as though there is very little present when a huge amount is present. Why does that happen with this assay? Well, part of it is because you're looking at relatively smaller antigens, but also remember I showed you earlier, there were only a few epitopes. Only the cloaked epitopes are looked at with this technique. Because of that, I believe we have a smaller equivalence region. And in order to find out the correct value, one has to perform many different dilutions to see antibody-antigen interaction at a range of antigen concentrations. This was described by McCudden and colleagues. They called it an antigen excess high-dose hook effect. And they recommended doing a delta check, looking at the serum-free light chain assays and diluting ones that had changed by more than 300 milligrams per liter between samples. For patients that have a previous history of a high-dose hook effect, if there is detectable monoclonal protein by serum protein electrophoresis, SPE, and immunofixation, but a normal ratio R of the serum-free light chains, FLC, you should also perform dilution studies. McCudden and colleagues also recommended comparing the results to the results of the intact M-protein spike. These findings were taken very seriously by the company that produces the serum-free light chain test, and they produced this package insert that provides many suggestions from the McCudden study. Okay, so this is the algorithm I originally showed you, doing serum protein electrophoresis and serum-free light chain test, and this has been the standard for some time. However, there is a new test on it that could be of some interest. It's called the heavy light chain test. What is that? Let's take a look at the immunoglobulin molecule. The immunoglobulin molecule consists of 2 identical heavy chains, gamma, alpha, mu, delta, or epsilon, and they're attached by disulfide bonds to two identical light chains, kappa or lambda. And we showed you that there were some determinants that were unique to the light chains that are hidden on the interior of the molecule. Well, when you combine the light chains to the heavy chains, that also creates unique determinants between the light chain and the heavy chains. Bradwell and colleagues got together again and created a very unique product. They found that they could create antibodies that would identify specifically IgG kappa molecules versus IgG lambda molecules, and IgA kappa molecules versus IgA lambda, etc. Here's a table from their paper showing how they developed their 95% confidence interval. They did studies on blood donors, and as you can see, they developed a normal range for IgG kappa, IgA kappa, IgM kappa, etc. And they also looked at the ratios, because just as with the monoclonal free light chains, the ratios are of key importance. Here showing the ranges for G kappa, G lambda, A kappa, A lambda, M kappa, and N lambda. So how do those work in practice? Okay, here's another figure from their paper. Again, we're graphing the IgG kappa versus IgG lambda. And you see that, as with the serum free light chain test, there is a normal range that I have in the blue rectangular diagonal bracket. And you see ones that have excess G kappa or excess G lambda. Myeloma patients are on the top and the bottom of it. Same is true for IgM and also for IgA. Now, IgA is an interesting molecule because, as we said earlier, it tends to migrate in the beta region, and it can be obscured by proteins that migrate in that region. So if we look at bottom left chart C, let's look at these particular 5 cases. They show them in D and E, which I'm going to enlarge on this next slide. Okay, these are 5 cases that they pointed out that they thought that the IgA kappa lambda ratio could help you, and in fact, it is helpful. Underneath the table, I've given you their normal reference range of 0.58 to 2.52. With the NHS, the normal human serum, you see the ratio that I've outlined in red is correct. It's 1.49. Above, you see the gel electrophoresis. But one thing I'd like you to note about this gel electrophoresis, it is of poor quality in terms of separation of the beta-1 and the beta-2 bands. I prefer a crisp separation because it makes it easier for me to see the bands. Let's take a look at the 5 cases that they show. Case number 1, I see a little band there, and maybe there's something in the gamma region, but that's all I can see. They describe it as a weak gamma band, and it does have a very abnormal ratio. And it is a weak band, but there's also something else about that case. Compare the gamma region to the normal human serum. The normal human serum gamma region looks darker. That's because there's normal amount of gamma globulin. They don't tell us the total amount of gamma globulin in these cases, but I would submit that all of these cases look like they're hypogammaglobulinemia. So these are cases that by the Narayan study or by Katzman study, I would want to do an immunofixation on anyway. But there's that band. Let's look at case 2. There's a very definite band here. They say that there are beta and gamma bands there and a very abnormal kappa lambda ratio of 44.4. It's certainly consistent and helpful. Case 3, they described as alpha-2 band. I had trouble seeing that. The alpha-2 region looks a little darker, but I actually thought that there may be a band here. And that one had a lower ratio of 13.5 than the other 2 cases, but still way out of the normal range. And here's another band in that sample. Case 4 is described as having a weak beta region band, and I think they're talking about this little area slightly cathodal to the major beta bands. But again, the beta bands are not well resolved in this, and it's harder to see. This gave a low ratio, 0.17, indicating it was a likely lambda process, and the normal range only goes down to 0.58. So again, helpful, but very hypogammaglobulinemic sample as well. Case number 5, they say multiple bands, and I certainly agree. I can see at least 2, and the range, once again, is low, but pretty darn close to the 0.58. So Heavy chain, light chain analysis, I think, is a very interesting area. There have been some recent studies that have shown that it may also be a very important, have an important use in stratifying risk for MGUS cases, but a lot of work needs to be done in other labs to confirm this information. It is intriguing. What are my conclusions from these studies? First, when you're screening for monoclonal proteins, serum protein electrophoresis with a method that shows good resolution is important. And also, there should be a method that can detect free light chains. You can use the classic urine immunofixation or serum-free light chain test. The Katzman study clearly shows it's at least as effective. Be aware of the high-dose hook effect with serum-free light chain test. It's a great test, but you do have to be aware of this. Immunosubtraction not only can be useful to classify M-protein type, but it is also useful to aiding in the measurement of the monoclonal protein itself. Finally, the heavy light chain test is a very exciting, promising new technique, and I suspect there'll be some really interesting studies that one will see in the future. Okay, I have one question. It says, in terms of mechanism, what causes a free light chain to be generated? Is it an aberrant production of antibody? That's an excellent question. Well, all plasma cells, you can view plasma cells as inefficient factories. They produce the light chains and heavy chains separately, but they also produce excess amounts of the free light chains. So not all the free light chains are bound to heavy chains. Those light chains are excreted into the serum. So even in normal people, we will have free light chains being excreted into the serum. I don't know why they're inefficient in this way. Maybe somebody else on the line can answer that question. But so it is a normal process that the free light chains, the plasma cells will produce excess free light chains. If you have a monoclonal gammopathy, now you have clones producing the same heavy and light chain, but they also will produce excess amounts of the free light chain type. And that can be detected in the serum by the serum free light chain test. Because they're small molecules, 25 kilodaltons for the kappa monomers, or 50 kilodaltons approximately for the dimers of lambda, they will pass into the urine. And you can detect them there by urine immunofixation. But the urine reabsorbs some of those molecules across the tubules. And so the serum immunofixation test, the serum free light chain test, is actually a little more sensitive than the urine immunofixation test because of that reabsorption. You don't get to see all the light chains in the urine. I hope that answers the question. I don't seem to have any other questions, so I hope you enjoyed this talk. Hope it is useful to you. You are welcome to email me at the University of Michigan. You've got my name and on the cover slide, and I'd be glad to answer any other questions you may have. So thanks very much for attending today.